Hello to everyone. Welcome to this joint session of the ESC with the European Society of Cardiology and Acute Cardiovascular Care Association. My name is Nikolaos Nikolaou, and I'm a cardiologist and intensivist from Athens, Greece. And it's my honor to co-moderate this session together with Christian Hasager from Copenhagen, Denmark, and Enrico Baldi from Pavia, Italy. Then let me directly introduce our first speaker, which Stefan Desk from Heart Centrum in Leipzig, Germany, who is going to talk us about the coronary angiography after ROSC in patients without ST segment elevation on the ECG.
So if you wonder who is sitting next to Nikolaos, that's me. Okay, thank you for the kind introduction. I'll just share my screen. So I think you should all be able to see it now. I'll talk a little about coronary angiography in out-of-hospital OCA patients without ST elevation. I have no disclosures. So if we talk about out-of-hospital cardiac arrest, let's first look at the causes. You can see here a registry from the Paris region, which was published some time ago. And you can see here a little more than 700 patients. About 2/3 of these patients might have some cardiac etiology of their arrest. The other third is clearly non-cardiac. And if you proceed and record an electrocardiogram, you will find in about 1/3 of these patients ST elevation. And if you take these patients to the cath lab, you can find a significant lesion, coronary lesion, in almost all of these patients. So the positive predictive value of ST elevation on the post-resuscitation ECG, if it's not very close to the event, say later than a few minutes, is very high. The other 2/3 are a little more interesting in my view. So there is still quite a high prevalence of significant lesions you can find if you take these patients to the cath lab, but it's not really perfect, and you can see only about 1/3 of these patients will eventually undergo a percutaneous coronary intervention. Let's first digress a little to the STEMI population. You can see here a comatose OCA patients with clear ST elevation in the inferior leads, hemodynamically stable. You can see the occlusion of the right coronary artery here. What's the recommendation in these patients? So the ESC recommends to take these patients to the cath lab as soon as possible with a class 1 recommendation and a level of evidence B, but there's never been a randomized study performed in this population. So in my view, it should rather be a level of evidence C. That's likely not going to change in the foreseeable future. So although nobody has ever proven that these patients really benefit from immediate intervention, it's pretty much clinical consensus to take these patients to the cath lab, and it's not much debated. There's also no ongoing randomized trials to study this question. So now let's move on to the patients without ST elevation. Here are some theoretical arguments in favor or against immediate angiography in these patients. So on the pro side, you can see what I would call the cardiac arguments. So you could possibly prevent a large myocardial injury or hemodynamic deterioration and possibly heart failure also in the long term. But that's only if there is really a treatable culprit lesion. So if you don't find anything, the catheterization was pretty much worthless. On the contra side, you can also find some arguments, foremost possibly a delay in the diagnosis and possibly also in the treatment for anything other than acute coronary syndrome. And then you have the risk of complications. You have the renal damage, contrast application, reperfusion injury, bleeding, and so on. So there arguments both in favor or against an immediate angiography in theory. What about randomized controlled trials? We are in quite a lucky situation. Now we have all in all now 4 published randomized trial. That's the smallest is the Pearl trial. And just last week, the Emerge trial from France came out. And then you have the 2 large trial, that's COACT, and our own trial, it's called Tomahawk. So I'm going to talk a little about Tomahawk since this is the trial I know best, but the results are pretty consistent across these trials. So there's not much heterogeneity between these 2 trials in terms of the primary outcomes. This is the basic design of Tomahawk. So we were looking for survivors of out-of-hospital cardiac arrest without ST elevation and randomized these to either immediate angiography, that is as fast as possible to the cath lab, just like in a STEMI patient, versus an initial intensive care evaluation with a possible but not mandatory delayed angiography in the later course if indicated. And the primary endpoint was pretty solid, 30-day mortality. Just a quick overview of the most important in and exclusion criteria. So we have the documented resuscitative out-of-hospital cardiac arrest with return of spontaneous circulation. So we are not talking about ongoing resuscitation patients. And on the exclusion side, you have the ST elevation patients, so those with hemodynamic or electrical instability, so no cardiac shocks were enrolled in these trials, and also the patients with in-hospital cardiac arrest, which make up a totally different population. These are some of the most prominent baseline characteristics. You can see about 1/3 of patients had a known CAD, about half of the population presented with a shock arrest rhythm, and the time from arrest to ROSC was 15 minutes in both groups. What about coronary artery disease? So you can see angiography was performed in almost all patients in the immediate group, whereas in the delayed group, it was only a little more than 60%. So some of these patients might have died in the meantime, and in others, there was probably an alternative diagnosis other than acute coronary syndrome, which didn't mandate coronary angiography. The time in the 2 groups between the arrest and the coronary angiography was a little less than 3 hours in the immediate group and about 2 days in the delayed group. We did find a culprit lesion in 38% in the immediate group and 43% in the delayed or selective angiography group. And this is the primary endpoint, all-cause mortality at 30 days. And you can see here, this is a non-significant result with a p-value of 0.06. So there was no statistically significant difference in all-cause mortality between the 2 groups at 30 days. Yet you could see there's certainly no superiority of immediate angiography. So let's look at secondary endpoints at 30 days. You can see there, numerically, there were more patients with severe neurological deficit in the immediate angiography group. And if you combine the 2 endpoints, neurological deficit and all-cause mortality, there is even a signal that you might harm these patients, although I have to say that this could not be replicated in the other trials. There were also no surprises in the subgroup analysis, so the primary results were consistent across all the studied subgroups. This is something we just recently presented, the all-cause death at 6 months, and you can see the p-value really has gotten down a little more to a value of 0.045 in favor of delayed angiography. The signal is now quite strong that we certainly should favor delayed angiography in the majority of patients. As I said in the introduction, there has been a new trial just published last week, the EMERGE trial from France, which was planned as quite a large trial, almost 1,000 patients, but had to be prematurely discontinued due to slow enrollment. So they ended up at a total of 279 patients. And you can see here, they also did integrate in their publication a nice updated meta-analysis of all the randomized trials. And if you look at the bottom, you can see there's practically zero difference in outcome in terms of mortality between emergency and delayed coronary angiography. And this is also the clinical message, I would say. So among patients with resuscitated out-of-hospital cardiac arrest of possible cardiac origin, both shockable and non-shockable arrest rhythms, and no STEMI, a strategy of immediate and unselected coronary angiography is certainly not superior to a delayed and selective approach with regard to all-cause death. And how could we translate these findings into clinical practice? So this is a suggested algorithm from my side, so it's not a consensus or guideline recommendation, it's just my personal opinion. In a comatose OCA patients with return of spontaneous circulation and no obvious non-cardiac cause. So you got the ST elevation or the shock patients, and it's generally agreed upon if the arrest setting is favorable. You can see what that means on the right side. To proceed to immediate coronary angiography, and for the patients with no ST elevation, you can take your time, do further diagnostics first, and if if there's a favorable arrest setting, and after a day or two you're still have a high likelihood of acute coronary syndrome as the trigger of the event, you can proceed to coronary angiography, but this has not to be performed immediately or emergently in the vast majority of patients. Thank you very much.
Okay, I just need my camera to go back on. Somehow it will not do so. Okay. Thank you very much for this elegant lecture and very interesting findings, and we'll get back to that in the discussion. We will then follow up with imaging, and for that we have assistant professor and an intensive care specialist, Guido Tavazzo from Pavia University in Italy. He also trained at Royal Brompton, and he has been very active in our Association of Acute Cardiovascular Care. So Guido, tell us about when do we need to do an echo in these patients?
Thank you very much, Christopher, for your kind introduction, and good morning, almost afternoon to everybody. So in the next few slides, we're going to go through some points regarding the role of imaging during the peri-arrest situation. No conflict of interest. And we will go through just very few points, which is the role in recognized cardiac performance, what the recommendation tell us about it, how the ultrasound may allow us or help us better to define the best pathway for our patient needs, and the role of monitoring of the efficacy of our resuscitation. So just a quick recall that the use of ultrasound, namely the cardiac ultrasound and the lung ultrasound, are stick in the recommendation of the Heart Failure Association and the European Society of Intensive Care Medicine since early 2015. So we got our evidence stick in there. Now, getting into the depth of this evidence. When we are talking about the cardiac ultrasound, mainly in the emergency setting, the peri-arrest situation, we're talking mainly about focused cardiac ultrasound, which means the application of mostly 3 different windows from the parasternal, tropical to subcostal to sort of have a full comprehensive evaluation of the heart, which stick perfectly in the emergency situation. But we do also know that in the ALS protocol that we're going to go through in the next few slides, we are advised at least to go counterclockwise, starting from the subcostal to avoid interruption and other impedance to the resuscitation maneuver. Now, the aim of the focused cardiac ultrasound, which we know now the technology has put the ultrasound in our pocket, is actually to define and recognize if you are dealing with a chronic pathophysiology, and to define whether there are and which are the gross abnormalities that may put your patient in difficulties during the acute setting. It has to be remembered very well, both in terms of training and in terms of diagnostic aim and description. The focused cardiac ultrasound should never be considered or reported as echocardiographic examination. There are two different things with different role and different timing. This is a busy slide just to show you that in the last 10 years, a huge effort has been put to develop protocols that include the cardiac lung and abdominal and all the other kind of ultrasound to better define the profile of our patient sleeping into the pericardiac arrest. So the first thing, as we just mentioned, is to recognize if we apply the shock stages, pericardiac arrest is stick mainly into the D when our patients in cardiogenic shock are sleeping into the worsening situation, not replying to the maximal therapeutic strategies. And so we have to be able to define whether this patient has a severe but chronic situation. As we can see here, there is a huge pericardial effusion, which is not a tamponade physiology, or big right ventricular dysfunction or biventricular dysfunction, which surely is putting our patient in severe hemodynamic condition, but not in the cardiac arrest, where these are some pictures taken from a patient that had a restore of a spontaneous circulation due to very recognizable causes that put our patient into the cardiac arrest, from the right ventricular myocardial infarction to the pericardial tamponade, severe left ventricular dysfunction or mechanical complication. So here is where the focused cardiac ultrasound actually may make the difference in recognizing the reasons why our patients get into the cardiac arrest. Getting into the evidence, that was the first seminal study published on resuscitation more than 10 years ago from the group of Raoul Troitz and Susanna Price. And it was an observational study in out-of-hospital setting. And that they were able to demonstrate that in the setting of not shockable rhythm, obviously, the pulsed electrical activity and suspected asystole, the application of the cardiac ultrasound was able to detect cardiac motility, cardiac activity. So in computing the diagnosis of suspected PIA and asystole in a remarkable percentage of patients, more than 50% in pulsed electrical activity and 35%-ish of suspected asystole. And also on a further analysis, they have demonstrated that those patients were those that had a better survival, those who were detected with a cardiac activity with ultrasound. There is another study published 6 years later after the ILCO guidelines of 2015, when this message was basically confirmed with this patient in an out-of-hospital setting. Again, the application of ultrasound allowed to define the cardiac activity in a good percentage of patients, and these patients were those who had a better outcome. Then I had to put your attention on the inter-rater reliability of the cardiac motion, which was remarkably low. And this will be one of the reasons why they stepped down from the recommendation. So this is a query taken from the ERC guidelines in 2015, when the ultrasound, was put into the ALS algorithm as usable. Not mandatory, obviously, but usable. And they asked to the scientific and clinical audience whether the ultrasound may change basically the outcome at discharge at some different time points. This is basically the reply from the last CIRCO guidelines, where the task force suggested against the use of point-of-care ultrasound for prognostication during CPR. That's the key word, for prognostication. And now let's see why. So this is a systematic review and a meta-analysis that is mentioned in the ERC guidelines. And we can see that the authors have estimated the sensitivity across a number of pooled studies that was around 62%, with good specificity, more than 90%, with unfortunately a high negative likelihood ratio and a positive likelihood ratio around 6.2. Then the authors defined the odds ratio, and they found that the odds ratio of the application of the cardiac ultrasound was 16 for the return to spontaneous circulation, around 12 for the survival to hospital admission, and 6 for survival to hospital discharge. So the authors conclude, actually, based on these results, that the cardiac activity on POCUS was actually associated with increased odds for the endpoint, but with a rather very low sensitivity and a high negative likelihood ratio, which turns, obviously, the level of recommendation for the ultrasound for prognostication rather low. That's another systematic review that is placed also on the website, where the authors take a bunch of very significant papers published over the last 10 years, and they have assessed a number of variables and the level of evidence. So they focus their attention on the outcome measurement, on the statistical analysis and the reporting that was fairly from moderate to low, actually, with the prognostic factor measurement, which was again from moderate to low. The conclusion of these authors was that the certainty of evidence of the application of cardiac ultrasound for prognostication during cardiac arrest was very low, due to a number of limitations that are quite easy to understand. Just to mention some of them, the treating physician was obviously not blinded to the ultrasound finding and suscitation, neither to the outcome. The clinical outcomes, which was mainly for the survival and different time point, but survival than outcome, and was not adjusted for other prognostication factors. And no measure of association for clinical outcome other than survival and outcome itself. Then there was a huge number of this study that did not have a specified timing for ultrasound. So again, timing is a key feature. Another very important limitation, there was an imprecise or unclear definition of ultrasound finding. It was very high heterogeneity regarding the description of findings. And there were a lot of other missing data. So the authors had to conclude, honestly, that the certainty of evidence, considering all the bias and limitation, was actually very low. So this is the evidence. Now, getting to the utility that hasn't been measured in the same way with the same structure and methodological pathway that have been applied to the outcome is the clinical utility. We do know that when we do find some treatable causes in out of hospital setting with a return to spontaneous circulation, if the geographical distribution of hospital allow, we may be able to define which is the best pathway of our patient and to bring our patient to the best place according to its need, whether coming from neuroprognostication, from ECPR, which is going to be the topic of the next talk, to the neuroprognostication assessment and to the cardiac surgery center, according to the level of ICU that have been defined in a publication a couple of years before. And another extremely important topic is the monitoring. we do rely now on indirect measurement of the efficacy of cardiac compression. There are very few case series. This picture comes up from our patient that was considered suitable for ECPR. They came to our unit, and he had a mechanical device. And when we stick the TOE probe to assess the validate the process for the ECPR, that was the find that we had, which is also described in a couple of case series. So we should be able to assess and monitor the efficacy of the cardiac compression. This is a good example of the patient that had chest compression and was obviously completely unable to generate stroke volume and then to generate perfusion. In the two clinical series, this finding was obviously associated with a worsened outcome of a patient as compared to those that had just the LVOT open and were able to generate stroke volume. So as a proof of concept, there are two papers in literature. One was on animal model and the other one was a pilot study on humans that suggested to look at the perfusion, just going beyond the chest, and to avoid interruption and all the limitation that we do know may be considered for the chest compression, and look at the carotid artery and to evaluate a direct visualization of the perfusion to the brain, which may reflect the perfusion to the whole body. So one of the latest reviews, considering all the limitations, still consider and advise to use the ultrasound has the ALS protocol patient suggests during the pulse check. Although recommendations say it's not useful for prognostication, but may have obviously utility for the clinical indication with big if, which are if this does not prolong pulse check, obviously, if the practitioners are adequately trained in the specific setting to define a diagnosis, or either to say, I'm not able to do to say anything regarding these pictures, if this ultrasound application may have clinical consequences, and obviously if the setting allows. So just to conclude, with more gap in evidence than evidence, and probably some of the things that we have to focus on in the next coming years for the study is a better definition of terminology around sonographic evidence of cardiac motion, so to reduce the heterogeneity of the findings. We probably should define specific and feasible endpoints. You know that the outcome may be influenced by a huge number of events in such a difficult population. So if we step back starting from clinical endpoints and build up a good and methodological robust study on outcome as a second instance could be a good pathway. And also, if we integrate some other ultrasound, including TOE maybe in a pre-hospital or in hospital setting, or other direct visualization of perfusion to assess what is key importance, which is the perfusion developed by the chest compression, could be another step to define the quality in our patients. Many thanks.
Thank you so much, Guido, for your excellent presentation. You highlighted many points that we can discuss later on in the discussion. And now move on to the last presentation about ECPR from Professor Susanna Price. She is a consultant cardiologist and intensivist and the clinical lead for critical care at Royal Brompton Hospital in London. Thank you, Susanna, for being here.
Thank you. Can I just check you can see my slides okay and you can hear me okay? Fantastic, yeah, thank you.
All okay.
Okay, so I'm going to take you briefly through ECPR and where we are now. I have no conflicts related to this or indeed any other presentation. So I'm just going to touch on why on earth are we talking about ECPR? And then I'm going to go through some of the big questions that we have around it at the moment. So who might benefit? When should we do it? Where should we do it? How should we do it? And is there any impact potentially on post-arrest strategies? So first up, why on earth are we talking about ECPR? So we do know that we're not doing really quite as well as we would like to be with conventional CPR. And except for certain subgroups, we've had some stagnation in terms of outcomes globally. We do know that if resuscitation is very prolonged, if it takes a long time to get ROSC, you're likely to have poor outcomes. We do know from observational and now emerging trial data that early deployment of VA ECMO can result in neurologically favorable survival in certain patients with cardiac arrest. And what we also know from ELSO, so that's the Extracorporeal Life Support Organization, is that the use of ECPR is increasing worldwide, despite where we are with the evidence. So there were fewer than 100 cases reported in 2009, and 10 years later, reported there were more than 1,500 cases. And that's a way underestimate of what is actually going on globally. So a lot of it is happening. There is emerging data, and we know that we need to try and think about different strategies to get better survival after cardiac arrest. We have international recommendations. So these are recommendations from the United States, again, all looking at in refractory cardiac arrest with selected patients. If you've got appropriate systems of care, you should be thinking about using CPR. And if we look at the ERC recommendations, in advanced life support, there's a consider extracorporeal CPR as one of your options if you are stuck in endless rounds of CPR and you're failing to get ROSC. So what does this actually mean? So you can see in this schematic that the blue squares are the right-sided chambers of the heart, the red squares are the systemic parts of the circulation. And for the large part, except for post-cardiac surgical cardiac arrest, what we're looking at here is peripheral VA ECMO, where we take blood from a central vein, we oxygenate it, and we deliver it back to the descending aorta. So that's it in pretty simple terms. So we take over the work of the heart during a cardiac arrest. So who should we be treating? So which patients might benefit from ECPR? So the simple answer is, well, of course, we want to pick the ones who are most likely to survive with a good neurological outcome. But when we're picking these patients, we have to think about the risks and benefits really, really carefully. So we have to think about what the outcomes are. And these, I think, have to be meaningful for the patient, not outcomes that just give you a nice p-value in your study. We have to be very careful that we are introducing complications that are not insignificant. So they may be hematological, so bleeding, hemolysis, thrombosis, and so on, or non-hematological, so LV distension. What happens when you change CO2 levels very rapidly in the brain? What happens to the endothelium when you're putting a patient on an extracorporeal circuit? And what about the complications of prolonged mechanical circulatory support that rack up your critical care complications that might not have occurred had your patient not survived? So it's really quite complex. ECPR isn't without risk, and there are also resource implications. And there's a very strong argument, I think, to look at the greater societal benefit as well. Should we really be focusing on doing the simple things that are very well evidence-based better, rather than trying to save a small number of patients with high-tech healthcare? That's up for major debate, I think. If we're trying to select patients, there are some risk scores that might help us. This is one of them. It was published earlier this year, and it looked at survival prediction for in-hospital cardiac arrest. It validated a group looking at Get With The guidelines versus an ELSO cohort. And what they showed was, of the non-modifiable risk factors that might predict outcome, patient type, presenting rhythm, the time of day, renal insufficiency, and age, and then with modifiable, the duration of arrest, you might be able to predict those patients that were more or less likely to survive. So we have got emerging risk scores, but of course there's always a problem with these, that you might have your overall potential improved survival in certain groups. But what about that individual patient? Do you really, really know? Even looking at the risk scores that you've got, the same problem as we have with the SAVE calculator. What about that individual patient? And picking the individual patient is extraordinarily complex. What about timing? So when should we do this? And I think this highlights what is emerging as a major theme in ECPR is, what about the duration of no flow, so no CPR, and low flow, so that would be CPR that's ongoing. And there are a number of studies, I've just pulled a few out here, So there's a very nice study by Bartos looking at 160 adult patients with ECPR for out-of-hospital cardiac arrest. This is the graph that I'm showing you here. And if the duration of CPR was 30 minutes or less than 30 minutes, all of these patients survived with good neurology. And you can see as resuscitation gets more and more prolonged, the neurological outcomes were less favorable. If you look at the Chen study, so this is for in-hospital cardiac arrest, you can see as the duration of CPR goes up, so 30 minutes, 60 minutes, 90 minutes, probability of survival goes down. And so the push is to implement CPR if you're going to do it as soon as possible, but obviously not too soon, because you don't want to dive in and subject the patient to all the complications when actually they may have improved spontaneously. So now we're looking at, well, what is refractory cardiac arrest? And we have a problem here because there is no clear definition between all of the ECPR studies, be they randomized or be they observational, as to what refractory cardiac arrest is. We know that survival declines after 10 minutes, and we know that even if you have prolonged ECPR runs, patients may do better. So what actually is refractory cardiac arrest? How do we define cardiopulmonary resuscitation duration for this? These are all challenges for our trialists. This is the most recent in terms of registry data. So this is just looking at the recurring theme about timing. This is a Japanese registry. You can see a large number of patients, so 695 patients, out of hospital cardiac arrest from a cardiac cause. And when they looked at the patients with a favorable CPC category, their call, so that was the emergency call to the onset of ECPR, so ECMO with ongoing CPR times, was shorter. So if you were able to do it quickly, they inferred then rapid onset of ECPR is likely to be associated with better outcomes. But again, this is registry data. They also noted a number of other factors that are associated with better outcomes or more favorable outcomes. So age, being male, shockable rhythm, intermittent ROSC, arterial pH, and intervening with PCI. These were all associated with more favorable outcomes. If we look at the meta-analyses that we have for in and out of hospital cardiac arrest that don't incorporate these newer data yet, they're relatively, although I think this is a slightly pessimistic interpretation, there's not really conclusive evidence right across the board to support ECPR, but the quality of evidence is low. And if high quality data comes, it may well change what these recommendations might be. And the high quality data is coming. So we're beginning to get our randomized controlled trials. So this is Dimitrios' study published in the Lancet. It's a phase 2 single center open label randomized controlled trial, out of hospital cardiac arrest, conventional cardiopulmonary resuscitation versus extracorporeal cardiopulmonary resuscitation or enhanced cardiopulmonary resuscitation, randomized on a hospital arrival, small study, 15 patients only in each group. And they showed us an impressive improvement in survival to discharge. I think it's important to note that in this study, although it's a fantastic study done very rapid onset of ECMO, the fragility index of this study was 1. So if one patient had been in a different group, there would not have been a significant improvement seen. It's a very, very small study. We have our friend Jan Belohlavek's study that's come out of Prague. So this is looking at an invasive treatment strategy. It's in a single institution in Prague, in the Czech Republic, 212 men, 44 women, randomized to a standard strategy or an invasive strategy. And their primary outcome was survival with good neurological outcome. This was at 180 days after randomization. They quite deliberately didn't look at 30 days because they didn't feel that that was meaningful for the patients. And unfortunately, it didn't show a statistical difference between the two that was significant. There's been a lot of discussion about this. It may have been underpowered. There was a higher than expected survival in the control group, probably reflecting what a fantastic center this was overall. But what they did do is they looked at certain subgroups that were predefined, and there was increased survival in the ECPR subgroup where there was prolonged resuscitation. So it may be that there are certain groups that might benefit, but unfortunately this trial didn't really help us. So our 2 randomized studies now, Dimitrios' study suggesting that ECPR versus ACLS cumulative survival was better with ECPR, and this hyperinvasive strategy from the Prague study showing no improvement in 180 days survival with improved neurological outcome. So we're being pulled in different directions. So clearly there is a signal there and actually some evidence that some patients may benefit, but obviously there's the downside of the risks of the intervention itself, and the timing and exactly which patients might benefit remains relatively unknown. These are the current recommendations in terms of who should we think about using enhanced or ECPR on. So younger patients, witnessed arrest, time to first CPR, so no flow, very short, initial potentially shockable rhythm, in particular VF and pulseless VT, now emerging data are really supporting those patients might benefit most. Arrest to ECMO flow, so your low flow interval of less than 60 minutes. Intermittent ROSC is potentially favorable. Signs of life during CPR might be positive, and end tidal CO2 that's recordable during conventional cardiopulmonary resuscitation. So we're beginning to drill down to which patients, but we don't really know. Then finally, I'm going to talk a little bit about practicalities. You've got time lags inherent to all of this. And all the way through, the signal is earlier is better. So if you're going to need to do ECPR, you need to do it rapidly. And organized systems of care clearly are required for this. Unfortunately, if you look at the EROCA trial, so this was a pilot feasibility study looking at a 911 call to ED and then an initiation of ECPR. And they wanted to achieve these relatively short times of less than 30 minutes in 80%. That was their aim in the study, and they failed. And this was even within a trial. So they were way, way short of the timings that were needed. There are some ongoing studies. So there's a sub-30 study, which is looking at remote ECMO with an ECPR team in London. And the APOCAR-2 trial, again, an ongoing randomized study looking at initiation and then transfer for in-hospital ECPR. So we may get more data from these studies down the line, but at the moment the feasibility of implementing this outside a highly organized system is really challenging. And then even if we look at in-hospital cardiac arrest, if you look at the registry data and the trial data that there are, the systems of care differ very, very significantly. So is it that it's been initiated pre-hospital or the randomization was pre-hospital? Did you initiate your ECMO pre-hospital or in-hospital? And then even in-hospital, was it in the cath lab? Was it in the ICU or was it in the emergency department? And then what about if you've initiated it even in hospital, transfer potentially to high volume centres where your post-resuscitation care may differ. There's a controversy again around who should cannulate. So if you look at the United States, emergency department ECPR, 78% of programs, it's cardiovascular surgeons. But it's emerging now that emergency physicians and intensivists and trained ECPR cardiologists, depending on the system of care, may be the best people to cannulate. So as yet, the jury is out. And in terms of access, I did mention central versus peripheral ECMO. So for most ECPR, peripheral percutaneous cannulation is most common in the adult population, has been shown to be associated with fewer infections, but of course there's the challenge of leg ischemia, and initiation of a leg cannula or so-called LEGMO to reduce limb ischemia is now considered fairly standard by most institutions. And then the post-arrest strategy, how does that change in ECPR? So coronary angiography is important. If you look at the arrest study, there was much more PCI undertaken and coronary angiography undertaken in the ECPR group versus the non-ECPR group. We don't yet know how to manage the temperature of these patients. Do we just avoid them getting hyperpyrexial, or do we go for hypothermia? These are the current recommendations here, aiming for 33 to 36. Anticoagulation is a real problem, especially in ECPR. You have differing coagulation profiles in these patients, and these abnormalities are seen prior to cannulation, so you can't quite blame the ECMO circuit. And neuroprognostication probably should be aligned with standard conventional CPR practices, but you're going to see much more brain death if you have an ECPR program, and determination of brain death demands particular consideration. And very finally, I can't talk about ECPR without touching on ethics. There's been a huge discussion in the literature about whether we should even be using ECPR during the COVID pandemic. And that touched again on the bigger benefit to society versus the benefit to the individual. But if one thinks about primary ethical principles, if a patient doesn't have COVID, the usual rules apply, provided constraints aren't too bad. And if a patient has hypoxia related to COVID and then has a cardiac arrest, it is likely their outcomes are going to be very poor. But in all groups, the impact of COVID on how we implemented CPR and continue to, and the uncertainties with, in particular, these changing backgrounds. So the changing baseline with the disease itself, with the different variants, with the vaccination profile, the changing availability of resources, the changing evidence base for outcomes on COVID-19, and an increasing fear of litigation, which comes when we're potentially seen to withhold life-saving therapies. These all need to be taken into consideration. And then very, very finally, what about the patients that might be organ donors? I'm not going to say very much about this because it's very country specific. The ethics around it are extraordinarily challenging. But if you're going to see more brain death with if you have an ECPR program, that means you potentially got more organ donors. And you're going to be seeing more controlled organ donation, i.e. after timed withdrawal of ECMO rather than uncontrolled. And that presents its own ethical challenges. So here are my take-home messages. There's huge promise here, but for selective individuals, and here are some of the features that might suggest that it might be more beneficial. It highly depends on a very efficient healthcare system, which is highly functioning. The ethical challenges are not insignificant, but if I was setting out on my research journey now, I would be saying this is a fantastic area for research, and I'd be looking to get involved in it as soon as possible. Thanks very much for your attention.
Well, thank you very much, Susanna, and thank all the speakers for the excellent presentations. And I'm sure now that we have many burning topics for discussion. Enrico, do we have any questions from our audience?
At the moment, we have no question in the app, but if the audience want to do some question, we are open to question on the official app of ERC in the Congress part. I have a question to Stephanie, if you want to start. I believe you highlighted a very interesting topic about the importance of correctly identifying STEMI patients. Your Tom Hawk trial highlighted that in a non-STEMI patient, probably the delayed coronary angiography is a good option. Obviously, in a STEMI patient, immediate coronary angiography is the best option. And the role of the electrocardiogram in the guidelines, both the ERC and the American Heart, is the first tool to be acquired after ROSC, but without any timing. With our data in Pavia, Vienna, and Lugano, we highlighted that it is better to wait some minutes after ROSC, because probably in the first 8-10 minutes after ROSC, there is the cardiac ischemia due to the cardiac arrest itself that can promote ST elevation. And so what is your thought about the importance of timing from ROSC to HG acquisition that actually is not specified in the guidelines?
Yeah, I couldn't agree more, Enrico. So the first few minutes are probably not the best time to acquire the ECG for further decisions. I'd say you could, of course, do it, but if it's within, say, like the first 10 minutes, you should do at least 1 second ECG later on, maybe at hospital admission. So as you said, whole body ischemia might produce ST elevation without being a classical ST elevation myocardial infarction. So that should be separated. And also when we digress a little, there might be some ST elevation myocardial infarctions in the non-ST elevation population, which are maybe in the CX territory. If you record only a 12-lead ECG, you might actually dismiss some of these patients. So the ECG is not a simple recording. You have to think a little.
Maybe we can follow up on that, Stefan. How should we handle boundary branch ECG, right and left boundary branch?
This is to the best of my knowledge, this has never been studied in the OCA population. So we all know the recommendations from the regular STEMI population that a left bundle branch block should be, a new left bundle branch block should be regarded as an equivalent of ST elevation myocardial. But even this is kind of on a weak data basis. In the population with out-of-hospital cardiac arrest, I'd be a little hesitant to interpret this as ST elevation.
I fully agree. I think clinical practice shows you that it's rarely a STEMI, actually.
To just my personal experience in now 20 years in cardiology, we have a lot of patients who are taken to the cath lab with left bundle branch block and supposedly some kind of angina. I have never in these 20 years experienced a single patient who actually displayed a classical STEMI lesion. Yeah, so
this is very important, I think. Yeah. Yes,
absolutely agree. We have some question in the app if you want, Nicholas.
Yeah.
From Professor Soar, what about patients with unstable rhythms or cardiogenic shock after ROSC for coronary angiography? Is the first one. And the second one is, what is the definition of early in early coronary angiography? So it's up to you, Stefan.
Yeah, I didn't really get the first part.
The first one is, what about patients with unstable rhythms or cardiogenic shock after ROSC for coronary angiography? How we can manage these patients?
So these patients were excluded from the randomized trials. If the arrest setting is favorable, I would recommend, just as a personal recommendation, to take these patients to the cath lab. So the cardiogenic shock population is a different one. And we have to rely on clinical judgment and clinical experience. You can't really extract any data from the randomized trials regarding this population. With regard of timing, what is early? In the randomized trials, which I've showed you, the 4 randomized trials, early meant immediate, as soon as possible. So the Tomahawk trial was actually the one with the largest time span, which was still under 3 hours. The other trials were even faster. In the registry studies, this was quite a liberal term. So some postulated within the first 24 hours, but really when we talk about early, we are hypothesizing that there might be something to save. And if you take this hypothesis, you should take the patients to the cath lab as early as possible. That is immediate.
Thank you so much. And we have the last question up to now for Guido. The role of transthoracic and transesophageal echo in ECPR, and also the role of ultrasound for vascular access, I suppose, for ECPR.
Yeah, thank you. So I just touched briefly the TOE for imaging. The role of what is the clinical practice actually, which is also been underlined in a recent publication on the on JACC, on the role of transesophageal echocardiography. For the ECPR, beside the clinical and the various indication that Susanna has shown brilliantly us in her presentation, validation for the ECPR should probably be given through the transesophageal echocardiography, whether no other reasons for cardiac arrest are identified with the transthoracic. And also a good clinical practice suggests to follow up the cannulation when it's performed peripherally with the transesophageal echocardiography if available, which also obviously allow a more comprehensive evaluation, including the clinical monitoring, which is of efficacy of a chest compression, which is extremely important. As Susanna showed us in one of her slides, the latest publication on Azayo suggested as the entitled CO2 threshold to be 10 millimeters of mercury, which is fairly low, at least in our clinical experience. The patient that I've shown you with a complete squeezing of the LVOT had 18 millimeters of mercury as entitled CO2. And we had a lot of patients with entitled CO2 above 15 millimeter of mercury, which is one of the thresholds we suggested for indication of the CPR, who had a very low quality chest compression and terrible outcome. So the direct monitoring of the efficacy of the chest compression should be done ideally with a transesophageal echocardiography, maybe with a transthoracic using a subcostal view, and or with other kind of ultrasound. And obviously, especially for the patient regarding the vascular ultrasound who are undertaking the ECPR, ultrasound guided vascular access, I would say, is almost mandatory. Otherwise, a bleeding complication from the vascular access is just what can put our patient in a worsened situation, even worsened situation. We had very bad experience about it.
Dana, do you have something to say on this?
Well, I was just going to say exactly what Guido said. I think the vascular complications from large bore access are really huge. And if you want to have a successful program and you want to have good outcomes, you need to minimize harm. And I think the use of ultrasound to guide vascular access, unless you have no option to do it, should be your routine standard of care. That I completely agree, Guido.
So thank you very much.
Maybe we can ask Susanna too about, right now we know we don't have the evidence for this, but what should we teach the emergency physicians? How long should they stay and play with a young guy? I mean, it's okay to pack it up and run for the hospital and then take the final decision there. How should we say, should they stay for 3 rounds, 6 rounds? What do you actually teach?
So so for me, I mean, it's a great question and it's one we don't know. So what's the practicalities? The practicalities are that one should focus on delivering high quality CPR for the evidence base. So, you know, your very, very high quality CPR needs to be established. So what you don't want to do is having people distracted from that because they want to do some high tech thing. So you want them to do the stuff that we know that saves lives and gives good outcomes, and you want them to do it well. What you don't want them to do is sit there and 25 minutes later go, well, do you think we should be ringing and asking for help now? That's kind of too long. And you begin to see this sort of fall off at about 10 minutes. So it's relatively early into your CPR that if you've got a patient that might have all of those favorable characteristics, you should be picking up the phone and saying, in an appropriate setting, that this might be a patient. What I would also urge is that we shouldn't really be doing these this kind of techniques that are very high risk, very resource intensive, detract from a lot of other things that may be possible to do outside either a registry or a randomized controlled trial. So I don't think people should be engaging in CPR programs unless they're part of a proper network and they are part of an ongoing trial. That I strongly feel that. Otherwise we will have it done badly, we will have bad outcomes. And if you look at the registry data, the truth of it is that you can help more people survive, but you will certainly see more brain death in these patients. And that's a catastrophe. So if people are going to embark on ECPR, call early if you think they've got a number of very positive characteristics. Do chest compressions well. Defibrillate when you need to. Do the basics really, really well. But in the back of your mind, be ringing early, particularly if it's a very favorable group. And if you're within a network that can do this, trying to do it ad hoc when you don't do it very often is a disaster. And I would make an absolute plea that there should be any patients that undergo ECPR should be part of a trial or part of a registry.
Okay, and then if I may, I would like to make a final question for Stefan. Stefan, okay, the lack of benefit with early angiography may be counterintuitive for some, but this is okay, and maybe it is perfect for interventional cardiologists on call as well, because they can do the job later at their ease. But what strikes me more in your data is the possibility for harm with early intervention. Can you please comment a little further?
Yes, at least in the Tomahawk trial, we conducted an analysis of a secondary endpoint, and that is severe neurological injury in the survivors. And we actually did find I'd say a trend signal that these patients who undergo immediate angiography actually might experience neurological harm. What could be the causes of this observation? Possibly a delay in the diagnosis if it's not a myocardial infarction. But I have to admit that this signal couldn't really be seen in the other trials. So we don't know yet, but it did certainly not point in the other direction.
Thank you very much. And I think that now we're running out of time. So I think it's time to thank our moderators and speakers for this very interesting session. Thank our audience for their kind attention, and bye to all.
Bye-bye.
Bye-bye.
Everybody, bye.
You're the last.